Welcome to Nurses Lab. Welcome to your PALS 2026 exam preparation. In the next 50 questions, you're stepping into the same high-pressure moments faced by real pediatric resuscitation teams, where every decision shapes an outcome, every second matters, and every action must follow physiology, not guesswork. These questions are designed to sharpen your recognition, strengthen your algorithms, and train your mind to respond with clarity when the room goes silent and the monitor alarms. From shock to arrhythmias, airway emergencies to post-arrest care, this practice test pushes you to think like the clinician a child needs in their worst moment. Take a breath, focus your mind, and step into the PALS 2026 challenge. Let's start.
Question number 1. A 4-year-old child is in cardiac arrest. The monitor shows asystole. High-quality CPR is in progress. According to the 2025 AHA pediatric guidance, what is the best next medication-related action? A. Delay epinephrine until after 2 full CPR cycles. B. Give epinephrine as early as possible. C. Give amiodarone first. D. Defibrillate immediately. Correct answer, B. Give epinephrine as early as possible. Let's see its explanation. For infants and children in cardiac arrest with an initial non-shockable rhythm, the 2025 AHA pediatric guidance says it is reasonable to administer the initial dose of epinephrine as early as possible. The cardiac arrest algorithm also places epinephrine ASAP on the asystole PEA pathway. Question number 2. A 7-year-old with an advanced airway in place is undergoing CPR. ETCO2 remains low. Which statement best matches the 2025 AHA pediatric guidance? A. ETCO2 should not be used during pediatric CPR. B. A single ETCO2 cutoff can be used to decide when to stop resuscitation. C. ETCO2 may be considered to monitor CPR quality, but a cutoff alone should not be used to end resuscitative efforts. D. ETCO2 is only useful after ROSC. Correct answer, C. ETCO2 may be considered to monitor CPR quality, but a cutoff alone should not be used to end resuscitative efforts. Now, let's see its explanation. The 2025 pediatric guidance states that in infants and children with invasive airways during CPR, ETCO2 monitoring may be considered to monitor CPR quality. It also specifically says a specific ETCO2 cutoff value alone should not be used as an indication to stop resuscitative efforts. Question number 3. A 9-month-old infant arrests in the PICU and already has an arterial line. During CPR, the team wants a hemodynamic target to judge compression quality. Which target is most appropriate? A. Systolic BP greater than 25 millimeters of mercury. B. Diastolic BP greater than 25 millimeters of mercury. C. MAP greater than 25 millimeters of mercury. D. ETCO2 exactly 25 millimeters of mercury. Correct answer, B. Diastolic BP greater than 25 millimeters of mercury. So what about its explanation? For infants and children with continuous invasive arterial BP monitoring during CPR, the 2025 AHA pediatric guidance includes diastolic BP targets as goals of high-quality CPR, greater than 25 millimeters of mercury in infants and greater than 30 millimeters of mercury in children at least 1 year old. Question number 4. A 6-year-old achieves ROSC after in-hospital arrest. Which blood pressure goal is recommended in the post-cardiac arrest period? A. Allow systolic BP to drift as long as pulse ox is normal. B. Maintain systolic and mean arterial pressure greater than the 10th percentile for age. C. Target only diastolic pressure. D. Maintain MAP below the 50th percentile to reduce afterload. Correct answer is B. maintains systolic and mean arterial pressure greater than the 10th percentile for age. Let's see its explanation. The 2025 AHA Pediatric Post-Cardiac Arrest recommendation is to maintain systolic and mean arterial pressure greater than the 10th percentile for age. Question number 5. A 10-year-old is ventilated after ROSC. Which oxygen saturation target best matches 2025 AHA pediatric guidance? A. Keep SpO2 100% continuously. B. Target SpO2 85% to 89%. C. Target SpO2 90% to 93%. D. Target SpO2 94% to 99%. Correct answer is D. Target SpO2 94% to 99%. Now let's see its explanation. After cardiac arrest in infants and children, it may be reasonable to wean oxygen to target an oxyhemoglobin saturation between 94% and 99%. Question number 6. A 3-year-old has suspected septic shock. Peripheral IV access is established. What fluid strategy is supported by the 2025 AHA pediatric guidance? A. Always give a single fixed 60 milliliter per kilogram bolus without reassessment. B. Give fluids in 10 milliliters per kilogram or 20 milliliters per kilogram aliquots with frequent reassessment. C. Avoid fluids entirely and start dopamine first. D. Use only colloids, not crystalloids. Correct answer is B. Give fluids in 10 milliliters per kilogram or 20 milliliters per kilogram aliquots with frequent reassessment. So what about its explanation? In infants and children with septic shock, the 2025 guidance says it is reasonable to administer fluid in 10 milliliters per kilogram or 20 milliliters per kilogram aliquots with frequent reassessment. It also says clinicians should reassess after every bolus for fluid responsiveness and signs of overload. Question number 7. A child remains in fluid refractory septic shock after appropriate reassessment and boluses. Which initial vasoactive approach is reasonable under the 2025 pediatric guidance? A. Epinephrine or norepinephrine. B. Lidocaine only. C. Adenosine first. D. Atropine first. Correct answer, A. Epinephrine or norepinephrine. Now let's see its explanation. For infants and children with fluid refractory septic shock, the 2025 pediatric guidance says it is reasonable to use either epinephrine or norepinephrine as the initial vasoactive infusion. Dopamine is a fallback option if epinephrine or norepinephrine are unavailable. Question number 8. A 2-year-old has profound bradycardia with altered mental status and hypotension. Oxygenation and ventilation have been provided, but the heart rate remains 55 per minute. What is the next best step? A. Observe because a pulse is present. B. Start CPR and obtain IV or IO access. C. Give adenosine rapid push. D. Defibrillate at 2 joules per kilogram. Correct answer, B. Start CPR and obtain IV or IO access. Now let's see its explanation. In the pediatric bradycardia with a pulse algorithm, if bradycardia persists with cardiopulmonary compromise, providers support airway and breathing. If the child remains compromised and the HR is less than 60 per minute, the algorithm says to start CPR, obtain IV or IO access, and give epinephrine. Question number 9. A 5-year-old with symptomatic bradycardia is suspected to have a primary AV block. Which atropine dose is correct? A. 1.0 milligrams per kilogram, IV or IO, may repeat twice. B. 0.02 milligrams per kilogram, IV or IO, may repeat once. C. 1 milligram IV or IO for all children. D. 0.2 milligrams per kilogram, IV or IO, may repeat once. Correct answer, B. 0.02 milligrams per kilogram, IV or IO, may repeat once, with minimum 0.1 milligram and maximum single dose 0.5 milligram. Let's see the explanation. In pediatric bradycardia with a pulse, atropine is used for increased vagal tone or primary AV block. The 2025 algorithm lists the atropine dose as 0.02 milligrams per kilogram. IV or IO may repeat once, with minimum 0.1 milligram and maximum single dose 0.5 milligram. Question number 10. An 8-year-old is pale and lethargic with a narrow complex tachyarrhythmia at 230 per minute, hypotension and poor perfusion. Vagal maneuvers fail, and there is no expert consultation immediately available. What is the best next step? A. Observe and repeat a 12-lead ECG later. B. Synchronized cardioversion starting at 0.5 to 1 joule per kilogram. C. Unsynchronized shock at 4 joules per kilogram. D. Immediate atropine. Correct answer, B. Synchronized cardioversion starting at 0.5 to 1 joule per kilogram. So what about its explanation? The pediatric tachyarrhythmia algorithm says that in a child with cardiopulmonary compromise, probable SVT should be treated with adenosine if IV or IO access is present, or synchronized cardioversion. The algorithm's dose detail is to begin synchronized cardioversion with 0.5 to 1 joule per kilogram, then increase to 2 joules per kilogram if needed, without delaying cardioversion for sedation.
Question number 11. A 10-month-old infant with bronchiolitis is lethargic and cyanotic. HR is 54 per minute, pulses are weak, and bag mask ventilation with oxygen has just been started. After effective ventilation, the HR remains 56 per minute with poor perfusion. What is the best next action? A. Observe because the infant still has a pulse. B. Start CPR and obtain IV/IO access. C. Give adenosine. D. Perform synchronized cardioversion. Correct answer, B. Start CPR and obtain IV/IO access. Now let's see its explanation. In pediatric bradycardia with ongoing cardiopulmonary compromise, once oxygenation and ventilation have been supported, persistent HR less than 60 per minute with poor perfusion requires CPR, IV/IO access, and epinephrine consideration. The trap is stopping after ventilation improves oxygenation, but not acting on the still dangerous heart rate and perfusion status. Question number 12. A 3-year-old with fever and dehydration has a heart rate of 178 per minute. The rhythm is narrow complex, P waves are visible, and the rate changes somewhat with crying and calming. Perfusion is preserved. What is the most likely rhythm? A. Stable SVT. B. Sinus tachycardia. C. Ventricular tachycardia. D. Atrial flutter. Correct answer, B. Sinus tachycardia. Let's see its explanation. A major trap in PALS is overcalling SVT. In children, sinus tachycardia is usually less than 180 per minute, often has visible or normal P waves, and commonly varies with activity or stress. SVT is more likely to have abrupt onset, little rate variability, and absent or abnormal P waves. Question number 13. A 9-year-old presents with palpitations, hypotension, altered mental status, and a narrow complex tachycardia at 240 per minute. A nurse asks whether sedation should be given before shock. What is the best next step? A. Delay shock until full sedation is achieved. B. Give atropine first. C. Perform synchronized cardioversion immediately. D. Start chest compressions first because the child is hypotensive. Correct answer, C. Perform synchronized cardioversion immediately. Now let's see its explanation. In pediatric tachyarrhythmia with cardiopulmonary compromise, synchronized cardioversion is indicated. Sedation may be used if it does not delay cardioversion, but instability takes priority. The classic trap is delaying life-saving electrical therapy while preparing sedation. Question number 14. A 6-year-old in pulseless VF receives a first shock of 2 joules per kilogram. VF persists. What is the recommended second shock dose? A.
1 joule per kilogram, B, 2 joules per kilogram again, C, 4 joules per kilogram, D, 10 joules per kilogram immediately. Correct answer, C, 4 joules per kilogram. Now let's see its explanation. In pediatric shockable arrests, the algorithm recommends 2 joules per kilogram for the first shock and 4 joules per kilogram for the second shock. Subsequent shocks are at least 4 joules per kilogram, not to exceed 10 joules per kilogram or the adult dose. Question number 15. A 5-year-old child is pulseless in PEA. High-quality CPR has begun, the airway is being managed, and the rhythm remains non-shockable. Which medication strategy is most appropriate? A. Wait until after the 3rd rhythm check to give epinephrine. B. Give epinephrine as early as possible. C. Give amiodarone first. D. Give atropine first. Correct answer, B. Give epinephrine as early as possible. Let's see its explanation. In infants and children with initial non-shockable rhythms, the 2025 guidance says it is reasonable to give the initial epinephrine dose as early as possible. The trap is waiting too long while continuing CPR cycles without timely vasopressor support. Question number 16. An intubated 8-year-old is in cardiac arrest. During CPR, the ETCO2 remains low, and one team member says this means resuscitation should be stopped. Which statement is most accurate? A. A single low ETCO2 value means resuscitation is futile. B. ETCO2 has no role in pediatric CPR. C. ETCO2 may help monitor CPR quality, but a specific ETCO2 cutoff value alone should not be used to decide when to stop resuscitative efforts. D. ETCO2 is only useful after ROSC. Correct answer, C. ETCO2 may be considered to monitor CPR quality. However, the 2025 guidance specifically warns that a specific ETCO2 cutoff value alone should not be used to decide when to stop resuscitative efforts. Question number 17. A 7-month-old infant arrests in the PICU and already has an arterial line in place. The team wants to use the line to judge compression quality. Which target is most appropriate? A. Diastolic BP at least 25 mm Hg. B. Systolic BP at least 25 mm Hg. C. MAP at least 15 mm Hg. D. Pulse pressure at least 25 mm Hg. Correct answer, A. Diastolic BP at least 25 mm Hg. So let's see its explanation. When invasive arterial monitoring is present during pediatric CPR, the AHA gives diastolic BP targets for CPR quality, greater than or equal to 25 mm Hg in infants, and greater than or equal to 30 mm Hg in children 1 year or older. The trap is confusing systolic MAP or pulse pressure with the actual recommended target. Question number 18. A 4-year-old with suspected septic shock has delayed capillary refill, tachycardia, and cool extremities. IV access is established. The child has no signs of pulmonary edema. What is the best initial fluid strategy? A. A single mandatory 60 milliliter per kilogram bolus without reassessment. B. 10 or 20 milliliters per kilogram aliquots with frequent reassessments after each bolus for responsiveness and signs of fluid overload. C. Avoid fluid and start lidocaine. D. Give atropine because tachycardia is present. Correct answer, B. 10 or 20 milliliters per kilogram aliquots with frequent reassessment after each bolus for responsiveness and signs of fluid overload. So what about its explanation? The 2025 pediatric guidance recommends 10 milliliters per kilogram or 20 milliliters per kilogram aliquots in septic shock with frequent reassessment after each bolus for responsiveness and signs of fluid overload. Question number 19. A 12-year-old achieves ROSC after in-hospital cardiac arrest. The ventilator is running with 100% oxygen, and the pulse oximeter reads 100%. What is the best oxygen strategy now? A. Keep FiO2 at 100% indefinitely because more oxygen is always safer. B. Reduce oxygen to target an SpO2 of 94% to 99%. C. Target an SpO2 of 85% to 89%. D. Turn off pulse oximetry and use only blood pressure goals. Correct answer, B. Reduce oxygen to target an SpO2 of 94% to 99%. Let's see its explanation. After pediatric ROSC, it may be reasonable to wean oxygen to maintain SpO2 94% to 99%. The trap is leaving the child in prolonged hyperoxia just because the arrest has ended and the saturation looks perfect.
Question number 20. A 5-year-old has ROSC after a prolonged resuscitation. The child is intubated and sedated. BP is borderline low for age. Which hemodynamic goal best matches the 2025 pediatric recommendation? A. Systolic BP only, above the 50th percentile. B. MAP only, above the 90th percentile. C. Systolic and mean arterial pressure greater than the 10th percentile for age. D. Diastolic pressure less than the 10th percentile for age. Correct answer, C. Systolic and mean arterial pressure greater than the 10th percentile for age. So what about its explanation? Post-cardiac arrest care in children should include maintaining systolic BP and MAP above the 10th percentile for age. The trap is focusing on only one pressure number or targeting an unnecessarily high percentile instead of the guideline threshold. Question number 21. A 6-month-old infant in the PICU arrests while already on invasive arterial blood pressure monitoring. During CPR, the team sees a systolic pressure of 58 mm Hg and a diastolic pressure of 18 mm Hg. ETCO2 is 14 mm Hg. The compressor says, the systolic looks okay. What is the best interpretation? A. CPR quality is adequate because systolic pressure is present. B. CPR quality is inadequate because infant diastolic pressure target has not been met. C. CPR quality is adequate because ETCO2 is above 10 mm Hg. D. Stop compressions and check rhythm immediately. Correct answer is B. CPR quality is inadequate because infant diastolic pressure target has not been met. Let's see its explanation. In infants and children who already have invasive arterial monitoring during CPR, the recommended hemodynamic target is diastolic blood pressure, not systolic pressure. The 2025 pediatric guidance recommends aiming for diastolic BP greater than or equal to 25 mm Hg in infants and greater than or equal to 30 mm Hg in children 1 year and older. This is a classic ICU trap because the monitor displays multiple pressures, but the target that matters here is diastolic pressure. Question number 22. A 4-year-old arrives in the ED with fever, delayed capillary refill, weak pulses, tachycardia, and cool extremities. The child receives a 20 milliliter per kilogram isotonic crystalloid bolus. The nurse reports new mild hepatomegaly and increasing work of breathing. What is the best next step? A. Automatically give 2 more 20 milliliter per kilogram boluses because 60 milliliter per kilogram is standard. B. Reassess for fluid responsiveness and signs of overload before more fluid. C. Stop shock treatment because hepatomegaly rules out sepsis. D. Give adenosine because the child is tachycardic. Correct answer is B. Reassess for fluid responsiveness and signs of overload before more fluid. Now let's see its explanation. The 2025 Pediatric Septic Shock Guidance recommends giving fluid in 10 or 20 milliliter per kilogram aliquots with frequent reassessment after each bolus for both response and fluid overload. The trap is reflexively pushing toward a fixed large volume endpoint without pausing to reassess. Question number 23. A 9-year-old regains ROSC after an out-of-hospital arrest and is being transported to the PICU. The child is intubated, hemodynamically stable, and has an SpO2 of 100% on FiO2 1.0. The transport team says, "Let's keep 100% oxygen until we arrive just to be safe." What is the best response? A. Agree because post-arrest patients should stay on 100% oxygen. B. Reduce oxygen to target an SpO2 of 94% to 99%. C. Reduce oxygen to target an SpO2 of 88% to 92%. D. Stop observing oxygen and focus only on heart rate. Correct answer is B. Reduce oxygen to target an SpO2 of 94% to 99%. So what about its explanation? After pediatric ROSC, the 2025 guidance says it may be reasonable to wean oxygen to target SpO2 94% to 99%. The transport trap is assuming that hyperoxia is harmless simply because the patient is post-arrest.
Question number 24. A 7-year-old in the ED has abrupt onset palpitations, a narrow complex tachycardia at 245 per minute, altered mental status, weak distal pulses, and hypotension. IV access is not yet available. What is the best next action? A. Obtain a 12-lead ECG before treatment. B. Try prolonged observation because narrow rhythms are usually benign. C. Perform synchronized cardioversion. D. Defibrillate immediately without synchronization. Correct answer? C. Perform synchronized cardioversion. Let's see its explanation. The pediatric tachyarrhythmia algorithm recommends synchronized cardioversion for tachyarrhythmia with cardiopulmonary compromise. Lack of IV access does not justify delaying treatment. Unsynchronized shock is for pulseless rhythms or when synchronization is impossible in certain unstable contexts, but the standard next step here is synchronized cardioversion. Question number 25. A 2-year-old with severe pneumonia in the ICU becomes progressively hypoxic. After effective bag mask ventilation with oxygen, the heart rate is still 52 per minute, blood pressure is falling, and mental status is worsening. What is the best next action? A. Continue observation because there is still a pulse. B. Start CPR and obtain IV/IO access. C. Give adenosine. D. Give synchronized cardioversion. Correct answer? B. Start CPR and obtain IV/IO access. So what about its explanation? In pediatric bradycardia with a pulse, once oxygenation and ventilation have been supported, persistent HR less than 60 per minute with poor perfusion is an indication to start CPR and move into the bradycardia algorithm's next steps, including IV/IO access and epinephrine. The trap is overvaluing pulse present and underreacting to severe bradycardic decompensation. Question number 26. An intubated 11-year-old in cardiac arrest is undergoing CPR in the ambulance. ETCO2 is persistently 9 to 11 millimeters Hg despite ongoing resuscitation. A team member says, "This proves further resuscitation is futile." What is the best reply? A. Low ETCO2 alone is enough to stop pediatric resuscitation. B. ETCO2 only matters after ROSC. C. ETCO2 may help assess CPR quality, but a specific ETCO2 cutoff alone should not be used to decide when to end resuscitative efforts. D. ETCO2 should always be ignored in children. Correct answer, C. ETCO2 may help assess CPR quality, but a cutoff alone should not determine termination. Now let's see its explanation.
The 2025 pediatric guidance says ETCO2 may be considered to monitor CPR quality in patients with invasive airways, but a specific ETCO2 cutoff alone should not be used to decide when to end resuscitative efforts. The trap is misusing ETCO2 as a standalone stop rule.
Question number 27. A 12-year-old in pulseless VF during interfacility transport receives a first shock at 2 joules per kilogram and remains in VF. What is the recommended second shock dose? A. 2 joules per kilogram. B. 3 joules per kilogram. C. 4 joules per kilogram. D. 10 joules per kilogram. Correct answer, C. 4 joules per kilogram. Let's see its explanation. The pediatric cardiac arrest algorithm recommends 2 joules per kilogram for the first shock, 4 joules per kilogram for the second shock, and then at least 4 joules per kilogram for subsequent shocks, up to 10 joules per kilogram or the adult dose. The trap is repeating the first shock dose or jumping straight to the maximum. Question number 28. A 5-year-old has ROSC after a prolonged arrest. The child is intubated and sedated in the ICU. The fellow says, "The blood pressure is low normal, so let's just watch." Which hemodynamic goal best matches the 2025 recommendation? A. Maintain only systolic BP above the 5th percentile for age. B. Maintain systolic and mean arterial pressure greater than the 10th percentile for age. C. Maintain diastolic BP below the 10th percentile for age. D. No BP target is recommended after pediatric ROSC. Correct answer, B. Maintain systolic and mean arterial pressure greater than the 10th percentile for age. Now let's see its explanation. The 2025 post-cardiac arrest pediatric recommendation is to maintain systolic BP and MAP greater than the 10th percentile for age. The trap is accepting borderline hypotension after ROSC because a pulse has returned. Question number 29. A 13-year-old arrives with chest discomfort and dizziness. Monitor shows regular wide complex tachycardia. While the team prepares a 12-lead ECG, the patient becomes confused and hypotensive. What is the best next action? A. Continue diagnostic ECG evaluation before treatment. B. Perform synchronized cardioversion. C. Give atropine. D. Start CPR immediately because all wide tachys are pulseless VT. Correct answer? B. Perform synchronized cardioversion. So what about its explanation? Once a tachyarrhythmia patient develops cardiopulmonary compromise, the algorithm shifts towards synchronized cardioversion. The trap is continuing rhythm analysis after instability is already clear. Question number 30. A 10-year-old in the ICU remains in pulseless VT after defibrillation and ongoing CPR. A resident asks, which medications are appropriate antiarrhythmic options in pediatric shockable arrest? Which answer is best? A. Adenosine or atropine. B. Amiodarone 5 mg per kilogram IV/IO bolus or lidocaine 1 mg per kilogram IV/IO. C. Calcium chloride first in all cases. D. Dopamine or norepinephrine push dose. Correct answer, B. Amiodarone 5 mg per kilogram IV/IO bolus or lidocaine 1 mg per kilogram IV/IO. Now let's see its explanation. In pediatric shockable cardiac arrest, the algorithm includes amiodarone 5 mg per kilogram IV/IO bolus or lidocaine 1 mg per kilogram IV/IO as antiarrhythmic options. The trap is confusing arrest antiarrhythmics with bradycardia or perfusion drugs. Question number 31. A 2-year-old with fever, dehydration, and crying has a narrow, complex rhythm at 176 per minute. P waves are present, and the rate fluctuates as the child calms. Perfusion is preserved. What is the most likely rhythm? A. SVT, B. Sinus tachycardia, C. Ventricular tachycardia, D. Atrial fibrillation. Correct answer, B. Sinus tachycardia. Let's see its explanation. In children, sinus tachycardia is usually less than 180 per minute, often has visible P waves, and varies with activity or stress. This is a classic ED trap because the rate looks dramatic, but the pattern fits sinus tachycardia rather than SVT. Question number 32. A 14-month-old with severe pneumonia becomes bradycardic during intubation in the PICU. After airway repositioning and effective bag mask ventilation with oxygen, the heart rate remains 52 per minute with weak pulses and poor perfusion. What is the best next action? A. Observe because a pulse is still present. B. Start CPR and obtain IV/IO access. C. Give synchronized cardioversion. D. Defibrillate at 2J per kilogram. Correct answer, B. Start CPR and obtain IV/IO access. So what about its explanation? In the pediatric bradycardia algorithm, once oxygenation and ventilation have been supported, persistent HR less than 60 per minute with cardiopulmonary compromise calls for starting CPR, obtaining IV/IO access, and giving epinephrine. The trap is assuming that pulse present means compressions are not indicated. Question number 33. A 6-year-old is intubated during a deteriorating resuscitation in the ED. The tube is in place and confirmed. One clinician says the team should now return to a 15:2 compression-ventilation ratio. What is the best response? A. 15:2 is required for all pediatric arrests. B. 30:2 is required after intubation. C. Use continuous compressions and give one breath every 2 to 3 seconds. D. Stop all breaths briefly after intubation. Correct answer, C. Use continuous compressions and give one breath every 2 to 3 seconds. Let's see its explanation. In the pediatric cardiac arrest algorithm, once an advanced airway is in place during pediatric cardiac arrest, the 2025 PALS cardiac arrest algorithm calls for continuous compressions and one breath every 2 to 3 seconds. The trap is reverting to a compression-ventilation ratio after the airway is already secured. Question number 34. A 15-year-old with suspected overdose is being transported after collapse. The patient has severe respiratory depression, bradycardia, and poor perfusion. After effective oxygenation and ventilation, the HR remains 48 per minute with hypotension. What PALS action is most appropriate right now? A. Delay treatment until the exact toxin is identified. B. Start CPR because HR is less than 60 per minute with poor perfusion despite ventilation. C. Perform synchronized cardioversion. D. Give adenosine rapid push. Correct answer, B. Start CPR because HR is less than 60 per minute with poor perfusion despite ventilation. Now let's see its explanation. Even in toxicology-flavored scenarios, the PALS algorithm is driven by the child's current physiology. When bradycardia persists with cardiopulmonary compromise despite oxygenation and ventilation, the algorithm directs providers to start CPR and continue the bradycardio pathway. The trap is over-focusing on toxin identification and delaying algorithm-based resuscitation. Question number 35. A 12-year-old in interfacility transport develops pulseless VF. The defibrillator is immediately ready. A team member says epinephrine should be pushed before the first shock to improve coronary perfusion. What is the best next step? A. Give epinephrine before the first shock. B. Shock immediately. C. Give amiodarone before shocking. D. Intubate before shocking. Correct answer, B. Shock immediately. Now let's see its explanation. In pediatric shockable arrest,
The algorithm prioritizes defibrillation ASAP. The 2025 guidance states that for an initial shockable rhythm, epinephrine may be reasonable after 2 shocks, or sooner only if rapid defibrillation is not possible. The trap is delaying the first shock for medications or procedures. Question number 36. A 10-year-old remains in VF after a first shock of 2 joules per kilogram and high-quality CPR. What is the recommended second shock dose? A. 1 joule per kilogram, B. 2 joules per kilogram again, C. 4 joules per kilogram, D. 10 joules per kilogram. Correct answer, C. 4 joules per kilogram. So what about its explanation? The 2025 pediatric cardiac arrest algorithm recommends 2 joules per kilogram for the first shock and 4 joules per kilogram for the second shock. Subsequent shocks should be at least 4 joules per kilogram, not exceeding 10 joules per kilogram or the adult dose. The trap is repeating the first shock dose or jumping immediately to the maximum. Question number 37. A ventilated child in the PICU suddenly becomes hypoxemic, develops markedly increased airway pressures, has absent breath sounds on one side, and then loses pulses into PEA. Which reversible cause is most likely? A. Hypothermia, B. Tension pneumothorax, C. Coronary thrombosis, D. Hypoglycemia. Correct answer is B. Tension pneumothorax. Let's see its explanation. The pediatric cardiac arrest algorithm includes tension pneumothorax among the reversible causes to identify and treat during arrest. In this scenario, unilateral absent breath sounds plus increasing airway pressure is the classic trap pattern. Question number 38. A child with renal failure in the PICU develops progressive weakness, then bradycardia, then arrests in a wide complex PEA rhythm. Which reversible cause on the PALS arrest algorithm is most directly suggested? A. Hypo or hyperkalemia, B. Pulmonary thrombosis, C. Cardiac tamponade, D. Hypothermia. Correct answer is A. Hypo or hyperkalemia. So let's see its explanation. The pediatric cardiac arrest algorithm specifically lists hypo or hyperkalemia among the reversible causes. A child with renal failure and progressive conduction abnormalities is a high-yield setup for this reversible cause trap. Question number 39. A 7-year-old regains ROSC after ED resuscitation and is now on the transport ventilator with FiO2 1.0. SpO2 is 100%. The team plans to leave oxygen at 100% during the whole transfer. What is the best target? A. Maintain SpO2 at 100% continuously. B. Reduce oxygen to target SpO2 94 to 99%. C. Target SpO2 88 to 92%. D. Ignore oxygen once ROSV is achieved. Correct answer is B. Reduce oxygen to target SpO2 94 to 99%. Now let's see its explanation. After pediatric ROSC, the 2025 guidance says it may be reasonable to wean oxygen to target an oxyhemoglobin saturation of 94 to 99%. The trap is assuming hyperoxia is always safer during transfer.
Question number 40. A 5-year-old remains hypotensive after ROSC in the PICU despite fluids and vasoactive titration. Which blood pressure goal best matches 2025 pediatric post-arrest care? A. Maintain systolic BP only above the 5th percentile. B. Maintain systolic and mean arterial pressure above the 10th percentile for age. C. Maintain only diastolic pressure above the 10th percentile. D. No specific blood pressure target is recommended. Correct answer is B. Maintain systolic and mean arterial pressure above the 10th percentile for age. Now let's see its explanation. The 2025 Pediatric Post-Cardiac Arrest recommendation is to maintain systolic BP and MAP greater than the 10th percentile for age. The TRAP is accepting low normal pressures after ROSC or targeting only one pressure variable. Question number 41. A 9-year-old presents with abrupt onset palpitations, a narrow complex tachycardia at 235 per minute, hypotension, and altered mental status. Vagal maneuvers fail. IV access is not yet available. What is the best next action? A. Wait for IV access so adenosine can be tried first. B. Obtain a 12-lead ECG before intervention. C. Perform synchronized cardioversion. D. Give atropine. Correct answer, C. Perform synchronized cardioversion. Let's see its explanation. In pediatric tachyarrhythmia with cardiopulmonary compromise, the algorithm directs treatment towards synchronized cardioversion. Adenosine is appropriate for probable SVT when IV/IO access is present, but instability means cardioversion should not be delayed while waiting for access or more diagnostics. Question number 42. A 9-year-old in the ED is in pulseless VF. The defibrillator is immediately available. One team member wants epinephrine before the first shock to improve perfusion first. What is the best next step? A. Give epinephrine before the first shock. B. Defibrillate first. Epinephrine comes after 2 shocks or sooner only if rapid defibrillation is not possible. C. Give amiodarone before the first shock. D. Place an advanced airway before shocking. Correct answer, B. Defibrillate first. Epinephrine comes after 2 shocks or sooner only if rapid defibrillation is not possible. Let's see its explanation. In pediatric shockable arrest, the algorithm prioritizes shock ASAP. The 2025 AHA Executive Summary adds that epinephrine in an initial shockable rhythm may be reasonable after 2 attempts at defibrillation or sooner only when rapid defibrillation is not possible. Question number 43. A 6-year-old is intubated during cardiac arrest. After tube placement, a resident says, "Pause compressions every few seconds so we can give breaths more accurately." What is the best response? A. Breaths should interrupt compressions once an airway is placed. B. Use a 15:2 ratio after intubation. C. Continue continuous compressions and give 1 breath every 2 to 3 seconds. Or D. Stop ventilations once the tube is in. Correct answer is C. Continue continuous compressions and give 1 breath every 2 to 3 seconds. Let's see its explanation. With an advanced airway in place during pediatric cardiac arrest, the algorithm calls for continuous compressions with 1 breath every 2 to 3 seconds. The TRAP is reverting to a compression-ventilation ratio after the airway is already secured. Question number 44. During transport, a 4-year-old is intubated after ROSC. Breath sounds seem present, but the team has not yet used capnography. Which statement is most correct? A. Breath sounds alone are enough to confirm endotracheal tube placement. B. Pulse oximetry confirms tube placement better than ETCO2. C. ETCO2 should be used to confirm and monitor endotracheal tube placement. D. Chest rise is unnecessary once the tube is inserted. Correct answer, C. ETCO2 should be used to confirm and monitor endotracheal tube placement. So what about its explanation? The pediatric cardiac arrest algorithm specifically lists ETCO2 to confirm and monitor ET2 placement. The TRAP is relying only on auscultation or saturation. Question number 45. An intubated 11-year-old in refractory arrest has ETCO2 values around 14 to 16 millimeters Hg during CPR. A clinician says, "That number is too low, so we should stop now." What is the best response? A.
A low EtCO2 alone is enough to terminate pediatric resuscitation. B. EtCO2 is useful only after ROSC. C. EtCO2 may help monitor CPR quality, but a cutoff alone should not be used to end efforts. D. EtCO2 has no role in pediatric arrest. Correct answer, C. EtCO2 may help monitor CPR quality, but a specific EtCO2 cutoff value alone should not be used as an indication to end resuscitative efforts. Now let's see its explanation. In children with invasive airways during CPR, EtCO2 may be considered to monitor CPR quality, but the 2025 guidance explicitly says that a specific EtCO2 cutoff value alone should not be used as an indication to end resuscitative efforts. Now let's move on to question number 46. A 7-month-old infant arrests in the PICU with an arterial line already in place. During compressions, the diastolic pressure is 21 millimeters Hg. The team notes that the systolic number looks acceptable. What is the best interpretation? A. CPR quality is adequate because systolic pressure is present. B. CPR quality is inadequate because the infant diastolic target has not been reached. C. The arterial line should be ignored during CPR. D. The target is MAP, not diastolic pressure. Correct answer, B. CPR quality is inadequate because the infant diastolic target has not been reached. Now let's see its explanation. In pediatric patients with invasive arterial monitoring during CPR, the 2025 guidance recommends targeting diastolic pressure, not systolic pressure. The target is greater than or equal to 25 millimeters Hg in infants and greater than or equal to 30 millimeters Hg in children 1 year or older.
Question number 47. A ventilated child in PEA suddenly develops unilateral absent breath sounds, increasing airway pressures and worsening oxygenation just before losing pulses. Which reversible cause from the pediatric arrest algorithm is most likely? A. Coronary thrombosis. B. Tension pneumothorax. C. Hypoglycemia. D. Cardiac tamponade. Correct answer, B. Tension pneumothorax. So let's see its explanation. The pediatric cardiac arrest algorithm specifically lists tension pneumothorax among the reversible causes to identify and treat during arrest. In this scenario, the abrupt ventilatory deterioration and unilateral findings are the classic trap clues. Question number 48. A child with renal failure arrests in the ICU. The rhythm is wide complex PEA after progressive weakness and bradycardia. Which reversible cause on the pediatric arrest algorithm is most directly suggested? A. Hypothermia. B. Pulmonary thrombosis. C. Hyperkalemia. D. Coronary thrombosis. Correct answer, C. Hyperkalemia. So let's see its explanation. The pediatric cardiac arrest algorithm includes hyperkalemia among the reversible causes. In a child with renal failure and progressive conduction instability, potassium disturbance is the high-yield reversible cause trap. Question number 49. A 5-year-old has ROSC after prolonged resuscitation. The child remains hypotensive despite ongoing critical care, and vasoactive support is being adjusted. Which hemodynamic target best matches 2025 pediatric post-arrest guidance? A. Maintain systolic BP only above the 5th percentile. B. Maintain systolic and mean arterial pressure at or above the 10th percentile for age. C. Maintain diastolic pressure above the 50th percentile only. D. There is no pediatric blood pressure target after ROSC. Correct answer is B. Maintain systolic and mean arterial blood pressure at or above the 10th percentile for age. Now let's see its explanation. After pediatric cardiac arrest,
The 2025 AHA guidance recommends continuous arterial pressure monitoring when appropriate resources are available, and recommends maintaining systolic and mean arterial blood pressure greater than 10th percentile for age. The TRAP is focusing on only one pressure value or accepting borderline hypotension. Question number 50. A 10-year-old remains comatose after ROSC. The ICU team is focused on blood pressure and ventilation, but the temperature drifts upward. Which statement best matches the 2025 pediatric guidance? A. Fever is acceptable as long as blood pressure is normal. B. Central temperatures above 37.5 degrees Celsius should be avoided in comatose pediatric post-arrest patients. C. Every comatose child must be cooled to 32 degrees Celsius. D. Temperature management is only an adult post-arrest issue. Correct answer is B. Central temperatures greater than 37.5 degrees Celsius should be avoided in comatose pediatric post-arrest patients. Let's see its explanation. After pediatric cardiac arrest, the 2025 AHA guidance states that avoiding central temperatures greater than 37.5 degrees Celsius can improve neurological outcomes in infants and children who remain comatose after cardiac arrest. The TRAP is overlooking fever prevention while concentrating only on circulation.
Thank you. You made it through all 50 PALS 2026 practice questions, and every answer sharpened your instincts you'll rely on when the alarms sound and the room shifts into resuscitation mode. If this session boosted your confidence, hit like right now so YouTube pushes this to more clinicians who need it. And if you're serious about mastering PALS 2026, subscribe and turn on notifications. New practice tests and AHA-related videos are coming every week. Stay sharp, stay ready. See you soon in our next video.